Alright, so obstructive shock is best defined as the obstruction of blood flow to either a great vessel or the heart. That's the best way to define it. This, of course, can be caused by a myriad of things, from a pulmonary embolism to cardiac tamponade to tension of the thorax. Let's start from an embolism. With an embolism, of course, that's when a blood clot prevents blood flow to the pulmonary arteries. To one or more pulmonary arteries, let's say that. This clot can, of course, lead to an increased resistance within the pulmonary circulation. This, of course, can lead to a reduction in cardiac output. That's with the embolism. With cardiac tamponade, it is caused by when blood flow leaks into the pericardium, begins to fill the pericardial sac, and basically it slowly begins to render the heart's output. It starts to slow it down. With tension in the thorax, it is quite the same thing. Basically, it's been the thorax that has not been dealt with fast enough, so now there's being tension added to the vena cava, to a great vessel. That causes a clot, which then also slows down cardiac output. For each of these, they all basically focus around the fact that it obstructs blood flow to the heart. And of course, without blood flow to the heart begins to show signs. Sorry, I had a brain fart. With a cardiac tamponade, you have muffled heart sounds, and your systolic and diastolic blood pressure the range of it begins to narrow. So you start to see like a mean differential that is starting to get lower and lower and lower. With a tension in the thorax, you'll start to see absent breath sounds in the affected area. You'll start to see uneven chest rise and fall, JVD. You'll see you have pulses periodoxis. You also have my brain is like tracheal deviation. I apologize, but you'll start to see these things within those patients. Embolism, same thing. You start to see low blood flow. You'll start to see tachycardia first before you see the decrease. When you start to see hypotension and hemodynamic instability, then you start to know you're going behind the ball. The best way to treat this, or either one of them, is basically to treat the main cause. So, of course, as you know, with tension in the thorax, it's a needle decompression. With cardiac tamponade, it is pericardocentesis, so you kind of need to drive fast. You need to transport the patient fast. And any of these, the main thing is immediate transport. Oxygen therapy, like using CPAP, BiPAP, patients with a pulmonary embolism might help. Consider the idea of using dopamine, but the main thing is treating the underlying cause. Treating the underlying cause can help with certain ones like the cardiac tamponade, but you can't do that usually in the field. Pericardocentesis is usually done in a cardiac center, so that's why the rapid transport is needed. Fluid resuscitation can be considered depending on the actual actual issue because it can make things worse. But yeah, that's the main thing. Just drive fast, consider oxygen, treat with medications like dopamine, IV access, just ensuring that the patient gets there, and inform ED that you're coming in with these patients, of course. That's the other main thing too. I think that's all I got with. No, wait, also. You might note a small QRS complex in these patients too, because of course the heart is beginning to fail. Outside of that, I think that's all I got. Thanks, guys.